Hello, I'm Paul Peterson. At some point in their lifetime, 1 in 4 Americans will have cancer, with more than 75% of all cancers occurring in people over 55 years old. With regular preventive screenings, many cancers can be detected early, when treatment has the best chance of success. Today, we'll be meeting a leading hematologist and oncologist who will be sharing how advances in treatment and new approaches to patient care are bringing new hope to patients and their families. Please stay tuned for Aging in LA. There are few of us whose lives have not been touched by the disease of cancer. And we know that earlier screening, diagnosis, and comprehensive treatment are essential to combating this disease. Today's guest, Dr. Eric McGarry, is going to share with us how encouraging new research and a complete care approach to focusing on the total health of patients is assisting in improving the care of cancer patients here in Southern California. Welcome, welcome, Dr. McGarry. Thank you so much for joining us. This is a big topic, and just to make sure I get this right, hematologists, so blood cancers?
Blood cancers,
right.
Benign hematology also. But
and oncology is just more generally cancer?
It's cancer. It can be blood cancers or solid tumors, what we call solid tumors.
Well, you can imagine with a show like Aging in LA, these issues of serious diseases are critical to our viewing audience. We're living in miraculous times. I can remember as a boy, I would hear someone had a cancer and poof, they were gone. But now we have really extended people's lives.
That's right. We certainly have. A recent report from the nation's leading cancer organizations have shown for the first time that the incidence of cancer in both men and women is falling, along with the death rate from cancer. So since this report was first made about 10 years ago, the death rates have been falling from cancer, which is excellent news.
Yes, sure
but this is the first time that they've shown that the incidence from cancer, or the rate of new cancers, is actually declining, as well as the death rate from cancer.
Wow. But we've added 25 years to our lives here in the last 50 years. That makes more opportunities for cancers to develop, correct?
It certainly does. And when we see the reduction in the rates and rise of cancer, we're seeing that mainly because the 3 most common cancers in men, prostate, lung, and colorectal cancers, as well as the 2 most common cancers in women, breast cancer and colorectal cancer, those are declining. And there's also a leveling off in the death rate associated with lung cancer in women, among women. So that's where we're seeing a lot of the gains, so to speak, statistically, as far as our war on cancer.
Right.
Yeah.
Well, there's nothing more challenging for a man than the prospect of colorectal cancer. Oh boy, we don't like the tests, and yet the tests really do help, don't they?
Well, the screening test, I think, is what you're referring for colorectal cancer.
Right. PSA or whatever that's called?
Well, for colorectal cancer, PSA is more for prostate cancer.
Okay.
For colorectal cancer, we usually do 3 different things for screening for colorectal cancer, and those 3 things are colonoscopy, a sigmoidoscopy, or fecal occult blood testing, which is just taking a little bit of a sample from the stool and determining whether or not there's blood in the stool, because most colon cancer cases have some blood that's shed off in the GI tract. We call that occult GI blood loss. And it's interesting, but 40% of patients in a recent survey showed that they did not even know or understand what any of the 3 tests were that could be used for screening for colorectal cancer. So 40% of the population isn't even aware of what the screening tests are for colorectal cancer. But it's important that they have this done starting at age 50.
And 50, that's kind of the time you should start it.
Yeah, 50 and older.
But for women, being a person who watches the news and all the rest, they're saying the screening for the mammograms and self-examinations should start much earlier than that.
Well, there's the recommendations for mammography are that people can get a baseline starting at age 40, but most women should be getting a regular mammogram study at 40 or at least start at age 50 getting an annual mammogram. Those are the recommendations.
And the pap smear as well, right?
And the pap smears, most recommendations are, it's really a yearly pap smear to reduce the chance of developing cervical cancer. But what most organizations recommend is that a woman have a pap smear done at least once every 3 years.
Once every 3 years.
Right.
And these are solid recommendations. You know, you grow up and people brush your teeth in the morning, brush your teeth before you go to bed at night. And yeah, it can be tedious, but darn it, it works.
It's very important. It's very important because, as you alluded to in the very beginning of the show, that we have the best chance of actually curing cancer when it's localized, when it hasn't metastasized or spread throughout the body.
Right.
Because then we're in a position where we're treating palliatively. We're trying to control the symptoms related to cancer or get the cancer under control, but we can't cure it. So we want to detect the cancer while it's still in the breast with mammography, or we want to detect the cancer while it's still in the colon with a colonoscopy, sigmoidoscopy, or fecal occult blood testing. And that's when we want to intervene as a medical oncologist.
Now, these interventions, it amazes me. I read these news articles, I'm going, holy cow, I didn't even know this new drug was being used. There's a whole range of treatments available to doctors today that, frankly, are new.
That's right, that's right. There has been a certain change in the paradigm in which we treat cancer. We talk about conventional therapies a lot, and the conventional therapies in general are things like surgery, okay? So if we can remove the tumor, that's the best, because we can cut out the cancer, we can usually cure, or oftentimes we can cure that cancer by just removing it if it hasn't spread throughout the rest of the body. Then we can use radiation treatments as well, okay? And so there's a role for radiation therapy. And then there are other roles for hormonal therapy or immunotherapy, but what most people hear about when they think cancer, and the first thing that goes into somebody's head is chemotherapy.
That's right. Losing my hair, being sicker than a dog.
Right.
And it's like the treatment is worse than the disease, it seems sometimes. And I've lived through some of these things in my life, and it is kind of frightening, the lengths that some people not so long ago had to go through to beat this disease.
That's right. You know, it was certainly a different disease to treat just 5 years ago. Just a year ago, it was a different type of disease to treat. But if you go back really into the 90s and into the 80s, people really suffered a lot from cytotoxic chemotherapy with things like nausea and vomiting. Now we actually found the area in the brain called the chemotherapy trigger zone where people actually react to the chemotherapy and have nausea and vomiting. And they have drugs now, medications, pills that you take at home, which can eliminate somebody's nausea and vomiting, what we call chemotherapy-associated or induced nausea, and can almost eliminate it in the majority of patients.
That's fantastic.
And so people really don't have the nausea or vomiting, but there's still that perception. And I would say at least 85% of patients coming to my clinic have the perception that they're going to be sick and having a lot of nausea and vomiting during their treatment.
Well, what about the illnesses? I mean, there are a cascade of side effects to cancer that sometimes can be so troubling, whether it's loss of vision or the loss of appetite, true impairments. How do you deal with the whole person when you talk to them about their cancer?
Well, and that's very true. And when we treat cancer, it's a very individualized treatment approach. So we don't just treat everybody that, for example, somebody that has stage 2 breast cancer. We don't, or stage 4 breast cancer or something like that. We don't group them all together, and we don't automatically treat everybody the same. We take a lot of things into consideration, especially in elderly patients. We take their performance status into consideration, and we take into consideration what their functional ability is at home, because we don't want to give them too much chemotherapy, and we want to suit the regimen that we give them or the treatment we give them to minimize toxicity.
Excellent.
Yep.
You know, recently we visited Dr. McGarry's office at Kaiser Permanente Hospital in West Los Angeles, where one of his patients graciously allowed us to record her visit. So let's take a look.
Hi, Carol. I'm Dr. McGarry. It's very nice meeting you.
Nice meeting you as well.
Okay. So tell me, now, you're here today because you're following up on a recent biopsy.
That's correct.
Okay. And my understanding is that you saw a general surgeon. You saw your primary care doctor who referred you to a general surgeon because you had an enlarged lymph node. And you palpated that lymph node underneath your left arm?
Yes.
Is that correct? All right. And what did he tell you?
He told me I had a lymphoma. He didn't specify what type it was, but it was lymphoma.
Right. Okay. So I bet you have a lot of questions.
Yes, I do.
Okay. And do you know anything about lymphoma?
Other than the fact that it's not a good thing to have, I really don't know what it's all about.
Right. Well, listen, I completely understand how you're feeling, okay? It is very frightening when somebody gives somebody a cancer diagnosis,
Yes,
okay?
it is.
And you don't have a lot of information about that, lymphoma is a cancer that involves the lymphatic system. Okay? So sometimes the organs that are involved with lymphoma are the bone marrow, lymph nodes, spleen, and liver. But there are a lot of different types of lymphoma, and that's what I want you to understand. Okay? You do have a type called non-Hodgkin's lymphoma. There's also another broad category called Hodgkin's lymphoma. And within these types, or these broad categories of lymphoma, there are subtypes of lymphomas. So it's often very confusing to patients, okay? Because one, they sound very similar, Hodgkin's lymphoma, non-Hodgkin's lymphoma. And then when you start to mix in all the different subtypes of lymphoma, it becomes even more confusing to patients. And especially when they get online and they start talking to each other and they start to compare their types of lymphomas. Because even though these lymphomas all sound the same, they're all very different, okay? And the treatments for them are very different. The prognostic features for each type of lymphoma are very different. So it becomes very, very confusing. And so my role is to kind of guide you through this type of lymphoma that you have, which is called a diffuse large B-cell lymphoma. So we want to see the extent of the disease, how far the disease has traveled throughout the body. As you know, lymphoma involves the lymphatic system. So for you, a good example was it involved a lymph node. And that lymph node was increased in size. Can you tell me, did you have any symptoms that went along with this? Or?
The only symptoms I had was I would have terrible night sweats. I'd wake up soaking wet.
Right. Okay, and that's a very common feature. That, you know, really common features with lymphoma are people have night sweats, sometimes people lose weight, sometimes people have a change in their appetite, sometimes people have a decrease in their energy level, or they have fatigue. These are all very, very common. Okay, these are what we call the physical signs or symptoms of non-Hodgkin's lymphoma.
Of which I had none
of
those symptoms.
Right. Now, the physical signs of a lymphoma typically are an enlarged spleen and an enlarged liver, which normally patients don't diagnose themselves. That's usually felt by a physician. Sometimes they'll have some pain in the abdomen, but oftentimes what patients will notice first and what takes them to the doctor is exactly what happened to you. You palpated an enlarged lymph node underneath your arm. Right?
Correct.
Right. Okay. But we won't know that until we do what we call a staging workup and find out the extent of the disease and see if there are any other enlarged lymph nodes in places that we can't see with our naked eye or we can't feel with our hands. Okay? So what I want to do is get a CT scan of your chest, your abdomen, and your pelvis. All this information will help us determine the stage, and once we determine the stage of the disease, then we'll talk about treatment options. But generally there are two types of treatment options. The first type is chemotherapy, and the second type is radiation treatment. So Carol, what are your concerns?
The word cancer is horrifying to me, and
Right.
I'm afraid of what the repercussions are, and just afraid of the treatment, and the word chemotherapy is frightening.
Right. Chemotherapy is very scary to most people, okay, so you're not alone. And fortunately, you know, the advances that we've made in what we call palliation, or the symptom control related to chemotherapy, has advanced remarkably over the last 10 years. Okay? In fact, it's very rare now that people even get nauseated with chemotherapy. Depending on the type of chemotherapy you get, you may not even lose your hair. But sometimes you will still lose your hair. So, Carol, I know we went over a lot of information today, and I know it's very, very confusing at this point. Okay, we're going to have a lot of visits in the very near future. Okay? First thing we're going to do is we're going to go ahead and order those studies. Okay? And we're going to set all that up for you right now. And then we're going to get you in the next 5 or 7 days, and we're going to do a bone marrow biopsy. And then I'm going to see you back in about 14 days. Okay?
Okay.
And then we'll sit down. We'll better be able to talk about exactly what stage disease you have and what is the most appropriate treatment.
The sooner the better, please.
One of the things that we're really going to focus on in our next visit when we talk about the stage and the treatment is we'll talk about the potential benefits of treatment, what are the goals of treatment, okay? And more importantly, and probably more importantly to you, is are there any toxicities or any things that you should be aware of or concerned about the treatment, okay?
Fine.
All right, good. All right, I look forward to seeing you then.
Thank you very
You bet.
much for your
Bye-bye.
time.
Oh, I'm glad we could see that. Gives you an idea how it is individualized treatment, without question. Now, you were talking about some of the new techniques that you have available to patients these days that are really new.
Right. Well, I think one of the things that we were talking about was chemotherapy and how that's very frightening to patients. And,
Yes.
and because chemotherapy really isn't necessarily directed to the tumor itself. Sometimes that just affects rapidly proliferating or dividing cells. So that's why you see the toxicity with hair loss or some GI symptoms or sometimes lowering of the blood counts because, you know, platelets and red blood cells and white blood cells, those turn over pretty quickly, so chemotherapy affects those.
Right.
Now, we've actually found out the switch for many cancers, what takes a normal cell and actually makes it a cancer cell. And so a lot of pharmaceutical companies have come out in the last just 5 or 10 years and developed these new drugs, offer them oftentimes in just pill form. So a simple pill, taking a pill once a day, that actually target that switch. And can actually target the switch. So they're very specific. They affect the tumor itself or the cancer cell itself, and they have very little toxicity for the rest of the person.
That's fantastic.
Yeah.
Now I imagine there are research studies going on all over the world now, because this really is a global business, isn't it?
Sure.
Are there environmental issues and lifestyle changes that people can be on the watch for to guard against the onset of cancer?
Right. I think one of the things that affects patients is they feel they lose control once they have a diagnosis of cancer. It's something that's out of their control. And one of the things that I always remind my patients is that there are things that they do have still in their control, or neighbors, friends, family, and that is lifestyle modification. Okay? Right. So it's always better to prevent cancer than to get cancer and then be treating the cancer.
Of course, yeah.
Even prevention. Prevention is worth a million. And even though you said it perfectly, I think that if people can modify their behaviors, they can reduce the incidence of cancer. And so we tell people, for example, stop smoking, and I think most people are pretty much aware of that nowadays.
And there are more smokers who have stopped than there are smokers now, because that message clearly has gotten through to the population.
That's right, that's right. And whereas people think, cigarette smoking is responsible for about 30% of cancer-related deaths. Wow. But it's responsible for about 80% of lung cancer deaths.
Right, I understand.
So that's one of the things I think is very surprising is people think, well, cigarette smoking is associated with lung cancer, but they don't know that it also causes oral cancer and throat cancer and pancreatic cancer. And it's been associated with bladder cancer and all these other type of cancers also. So behavior modification, reducing regular alcohol consumption. There's some evidence that that may reduce the risk of developing some solid tumors, and diet modification as well.
Okay, we're going to come back to this topic, but right now it's time for a short break. So when we come back, we will continue our discussion with Dr. Eric McGarry, hematologist and oncologist, on early screening and comprehensive treatment of cancer. We'll be right back, friends, on Aging in LA.
Hey, buddy! Don't you know you should never leave a cooking pan unattended? And a working smoke detector can warn you of a fire. Like the one behind me. My hero!
Next time, listen to the ball. Have a smoke detector and a fire extinguisher that work. How'd you know? The ball called.
The Department of Public Works Bureau of Contract Administration keeps the city's projects on track, ensuring safety first and fairness always, from the streets all the way to the stars.
Welcome back to Aging in LA. Our topic today, combating cancer. And our guest is Dr. Eric McGarry, a leading hematologist and oncologist. Thanks again for joining us, Doctor. This is, you were talking before the break about how smoking actually is involved with many other diseases than just the traditional lung cancer.
Right, so behavior modification is very important, and stopping smoking, of course, is important. Reducing your exposure to ultraviolet light, wearing sunscreen when you go out, reduces your risk of developing common skin cancers and malignant melanoma, things like that.
Which is lethal, if not.
Which can be lethal.
Yeah.
Some skin cancers usually are not, can be easily treated with simple procedures. But also, diet modification is very important.
Right.
So, for colorectal cancer, eating a diet that is low fat and high fiber, lots of vegetables, lots of fresh fruits, that kind of thing has been shown or been associated with possibly a reduction in the risk of developing certain types of solid tumors.
Well, now, what about environmental issues? The air we breathe, the chemicals that we're exposed to. It is, I have some friends that work down in the port. And I worry so about them because they are in a chemical soup down there.
Right.
And are there steps people can take, ways to cleanse their body, perhaps, of this, or a diet that sort of guards against some of these environmental issues?
Right. Well, certainly, you know, we do know that certain types of environmental exposures are linked to certain types of malignancies. Asbestos exposure
Asbestos, yes, I'm
is a very good
thinking of that.
example of that. Benzene exposure, chemical exposures, people that work in certain types of manufacturing plants.
Yeah,
have
benzene
a higher,
is in our gasoline.
right, might have a higher incidence of developing leukemias, that kind of thing.
Wow.
So I think just being aware of your surrounding, you know, where you're working, what you're working with, and then meeting with the people at your industry or your workplace. And usually they'll have some sort of occupational health or some sort of safety control office there.
Right, most always.
Right.
Now, you're in a clinic situation with Kaiser Permanente, and you see a lot of people. In any given month, are these gigantic numbers that you're dealing with, or is this the kind of thing where this is your practice? You have 300 people in a month.
Right. Well, this is pretty much the standard practice, I would say, is the numbers are, we'd like them to be smaller. Most oncologists would like to be out of business. We would like to have other jobs we'd have to go to.
From your lips to God's ears.
That would be very, very nice, yes.
Yeah.
But it is very busy. Even though we see a decline in the death rates and the incidence of cancers, we're still very, very busy. And that's probably because the population of patients that are aged 65 years and older, 65 years of age and older, is increasing.
Oh, it's exploding.
That patient population is going to be, I think it's going to be about 20% of the general population.
That's correct. And
by 2030.
And 25% of the workforce. Can you imagine?
That's right, working longer and later.
It's going to be different.
That's right.
So, well, that's you.
That's me, you're right, exactly. But that's a good thing, though.
Well,
that can be a good thing.
But it is. And yet, by seeing enough people, you get a broader sense of this disease than the general practitioner in a small town in the Midwest. I mean, you're being exposed to a wide variety of cancers.
Right. I think generally, though, that most common cancers are the most common cancers wherever you really are.
Wherever you are?
Wherever you are. So for men, you know, it's prostate, it's lung, it's colorectal. And for women, it's breast and it's colorectal cancer. Those are really the most common cancers. And that statistic or that demographic kind of holds no matter where you are in the nation, generally speaking. Yeah.
Now, with Kaiser Permanente, they have this wonderful resource base in that they have a lot of patients.
They do.
So they are involved in a lot of studies.
They are involved in a lot of studies. In the oncology department at Kaiser, we have we have between 40 and 50 clinical trials actually in oncology. Kaiser is very, very proactive regarding the Thrive message that we try and get out, which is maintaining your health. Prevention, prevention, prevention. How to stay healthy longer in life. How to be more active as you get older in life. Okay, and so we have a lot of outreach programs. We have smoking cessation clinics. We have something called the 1-800 Healthy Living line. So if you want to stop smoking or you need advice on how to get physically fit or increase your exercise program or change your diet, we have dietitians that can meet with people or counsel them over the phone on a 1-800 number. All of these things we do to keep our members healthy longer.
Right, and of course you can reach Kaiser Permanente, their website, if heavily trafficked, kp.org, so it's there on your screen. What about the people who are caregivers? Not so much the cancer patient themselves, but family members. Are there supports for them as well so they can understand the process?
Sure, sure. We have many different support groups for different types of cancer. For example, we have a multiple myeloma support group. So patients can come to that. They can meet each other, which is a really great forum so that they can share their experiences. What are they doing to manage some of the side effects they may be having? Or how are they doing as far as their outside activities and providing support to one another? Because they're going through this together. And then they usually come and they bring their support group, which is their families and their friends. And, you know, it's not just the patient that's living with cancer or getting treated for cancer that needs support. It's also the family members.
Absolutely.
Right.
That is true. I know we have actually talked with people who run programs for the person at the end of days to help support and nurture the family so that death is not necessarily the end. It may be of the individual, but you go on. There's continuance in this, and for many people, that's a great comfort to them in their last days. What can we look for in future cancer treatments. Where's the research going to take us? Am I going to be able to take like a radio-controlled pill?
Right. Well, you know, there are so many different avenues that people are exploring for cancer treatment. I mean, the whole area is just thriving right now. I think you're going to see more molecularly targeted drugs. Okay, and that we will still use general chemotherapy, but you'll see more of the molecularly targeted treatments. I think that treatment is going to become more and more individualized and specific for the person as well as that person's tumor. So what specific features does that patient's tumor have? If they have breast cancer, that's different from another patient's breast cancer.
Right.
How can we target their breast cancer, whereas it may not target another person's breast cancer? So we're targeting not only the patient specifically, but their specific features of that specific tumor.
Wow. And to stay abreast of these changes, you must have to read a mountain of material.
It's a lot of material. And it's not just the medical oncologists, it's the radiation oncologists. You know, we're making breakthroughs with radiation treatment and with minimally invasive surgery. We do robotic surgery at Kaiser Permanente now.
Right, I've heard about this. Wow.
Very exciting.
Yeah,
very exciting.
Bobby the Robot.
That's right.
That's really fun. Well, Doctor, unfortunately, our time is up for this segment. Thanks to our guest today on Aging in L.A., from Kaiser Permanente Hospital in West Los Angeles, Dr. Eric McGarry. And now, it's time for today's Senior Stat Shot. As we have heard today, cancer prevention is easier than you might think. With a few simple lifestyle changes, you can drastically reduce your risk of many types of cancer. Number one, avoid smoking, whether it be actual smoking or secondhand smoke. 2, practice sun safety and recognize when skin changes occur. Eat your fruits and veggies. A diet rich in fruits and vegetables greatly reduces your risk of developing cancer and also many other conditions. 4, limit how much red meat and animal fat you have in your diet. Red meat contains much more fat than poultry and fish. Limit your alcohol intake. Drinking excessive amounts of alcohol regularly increases your risk factor for many types of cancer. Exercise for cancer prevention. The American Cancer Society recommends exercising for 30 minutes or more at least 5 days a week. Know your personal and family history of cancer. It's important to properly assess your risk factors for certain types of cancer. Know what chemicals you are being exposed to in your work. If you are exposed to fumes, dust, chemicals in the workplace, you have a legal right to know. Practice safe sex. Unsafe sex can result in an infection that could cause cervical cancer. Number 10, get screened for cancer regularly. Screening tests like the colonoscopy and pap smear can detect abnormal cellular changes before they turn cancerous. Mammograms and other imaging tools are recommended to detect breast cancer in women. Remember, many factors play a role in cancer development, but the good news is that most can be avoided. And that's today's Senior Stat Shot. The Los Angeles Department of Aging produces this program with CityView, Channel 35, so that seniors living in Los Angeles and surrounding communities are well informed on the many issues that face them in everyday life, and also to let you know of the many services that the Department of Aging offers our senior citizens. Now, we'd like to hear from you with comments on the program, what you like, what you think can be improved, and ideas for future programs. So please give us a call. The number's there on your screen, area 213-252-4088. That's 213-252-4088. Call us with your comments and ideas. We look forward to hearing from you. I'm Paul Peterson for the Los Angeles Department of Aging, the people here at CityView Channel 35, and all of our guests on Aging in LA. Thank you so much for watching, and we'll see you next time.